Hello. So today I'll be talking about a very common problem, which is constipation during pregnancy. So incidence is quite high. It's 11% to 38% of pregnant women, and compared to nausea, it is the second most common gastrointestinal complaint during pregnancy. So first we'll know the etiology so that we can find out how to overcome all these problems. So first, most important thing is rising progesterone level, which reduces the smooth muscle contractility, and reduced mortelin hormone, which leads to increase in bowel transit time. GI transit time is significantly prolonged in the second and third trimester to almost 125 to 137 minutes compared to first trimester or the postpartum period when it is 75 to 99 minutes. There is increased water absorption from the intestine, which leaves the fecal matter dry. Decreased maternal activity during pregnancy, increased vitamin supplementation, for example, iron and calcium, especially from the second and third trimester, and enlarging uterus might slow onward movement of feces. And why we should treat it? Constipation causes impaired quality of life. It causes a lot of distress for pregnant women, and there could be some physical problems arising out of it, like hemorrhoids. What are the non-pharmacological treatment for constipation? First and most important is increased dietary fiber. So naturally occurring dietary fiber comes from plants like fruits, but we should take care of other common things like we should avoid papaya in the fruits, vegetables and whole grain cereals. Dietary fiber is indigestible and it therefore retains water, thus increasing fecal weight and volume. We should ensure adequate water intake, which could be around 8 to 10 glasses of water or 2 to 2.5 liters of water per day. Moderate physical exercise, which means any activity that is equivalent in difficulty to brisk walking. The recommendation for pregnant women with no medical or obstetric complication is 30 minutes a day of moderate exercise on most, if not all days of the week. Now we will come to pharmacological treatment. So now we will go through different types of medicines which are available for constipation, and we will also know their examples with their doses, mechanism of action, side effects, pregnancy category, and how frequently they are really used in practice. So in brief, just we'll go through the pregnancy category definitions. So category definition A is generally acceptable. Category B is may be acceptable. Either animal studies show no risk but human studies not available, or animal studies showed minor risk and human studies done and showed no risk. Category C is use with caution if benefits outweigh risk. Animal studies show risk and human studies not available, or neither human, animal, or nor human studies done. Category D is use only in life-threatening emergencies when no safer drug available. Positive evidence of human fetal risk. Category X is do not use in pregnancy. Risk involve outweigh potential benefits and safer alternatives already exist. Okay, so the first type of medicines are bulk forming agents. Most commonly used one is psyllium, also known as isabgula husk. The dose is 6.4 to 10 gram per day. Others are methyl cellulose, dose is 4.8 to 9.6 gram per day, or polycarbophyll with doses 2 to 8 gram per day. They expand with water to increase the stool bulk. Their desired effect may take a few days to achieve. So it is not appropriate for acute treatment, and patient must be warned about it that his her stool will become normal only after 2 to 3 days. The side effects are gas, bloating, and cramping. It comes in the pregnancy category of category B. It is safe for long-term use. It is the most physiologic and safest type of medicine, and it is the first line of treatment. If suppose bulk forming agents don't succeed in achieving the normal bowel movements, then we go to the other categories of medicines. The second most commonly used is osmotic laxatives. There are three categories in this. So saccharides like lactulose and sorbitol, dose is 15 to 30 ml per day. Second class is salt osmotics, magnesium, sodium salts. So magnesium oxide dose is 30 to 45 ml per day. Third is polyethylene glycol, 17 to 34 ml per day. They are hyperosmolar laxatives because they are very less absorbed, and they increase stool water content due to their osmotic properties. The side effects with saccharides are flatulence and bloating. And for salt osmotics, especially the sodium salts, they can cause maternal sodium retention, and therefore they are not used. PEG can cause abdominal bloating and cramps. PEG is polyethylene glycol. Category pregnancy category for lactulose and magnesium oxide is category B. For rest, it's category C. It is again comes under the first line of treatment, and though the PEG comes in category C, nowadays it is quite commonly used even more than the lactulose. The stimulant laxatives are Senna, which is used in dose of 7.5 to 30 milligram per day, and Bisacodyl 10 to 13 milligram per day if used orally, or 10 milligram per day if used rectally. They act on myentrid plexus to stimulate the colonic motility and decrease water absorption from large intestine. The side effect is many times they cause severe diarrhea leading to electrolyte imbalance. Pregnancy category is category C for Senna, and Bisacodyl it's category B. And they are used, but they are not used on regular basis. They are suitable only for the single dose use. Next is stool softness, emollient laxatives. Example is docusate sodium, 50 to 500 milligram per day orally. It stimulates the net secretion of water, sodium, chloride, and potassium, and inhibits the net absorption of glucose and bicarbonate in the jejunum. The side effects are again it can cause loose motion and electrolyte imbalance, and there was a case report of hypomagnesemia in the neonate. It comes in the category C and it is not used. Next is lubricant laxatives, mineral oil like castor oil or paraffin. There is no direct effect on the gastrointestinal mucosa. They have a direct lubricating effect on stool, and therefore they help in passage of the stool. They reduce the absorption of fat soluble vitamin, but it is theoretical. And castor oil may cause premature uterine contraction. So, castor oil should never be used before the 40th week of pregnancy. So, castor oil comes in the category X and paraffin in the category C, and they are mostly not used. Now, prucalopride, which is very commonly nowadays used in the adults, dose is 2 milligram per day. In elderly, it is 1 milligram per day. It is a 5-HT4 serotonin receptor agonist and increases colonic motility. The side effects are headache, abdominal pain, diarrhea, and nausea. Though it has been kept in the pregnancy category as not safe, but it is not systemically absorbed, and I think it can be used. Next is lubiprostone, which is quite effective. It is 8 to 10, 24 microgram twice daily. It increases chloride and fluid secretion in the GI lumen and leads to increased peristalsis. The side effects are vomiting, nausea, and abdominal cramping. It comes in under category C because not much trials have been done on lubiprostone, but it is not absorbed at all systemically. So I think it can be used during pregnancy. So now we'll go through the bulk forming agents in a bit detail. Xylem isabgula is a natural fiber, but it is known to ferment in the colon, and the common side effects are delayed gastric emptying, loss of appetite, and less frequently it causes serious acute allergic reaction and asthma. Methyl cellulose is a synthetic polymer fiber, and it is resistant to bacterial fermentation. Likewise, polycarbophil is a hydrophilic resin, and it is not metabolized by intestinal bacteria, and therefore methylcellulose and polycarbophil are less likely to cause gas and bloating. We will just touch upon the enemas and suppositories also. There is a marked difference between an enema and suppository. An enema is a liquid that is inserted into the rectum using a nozzle attached to a bag made of plastic or cloth. The liquid is forced into the rectum through this device to relieve occasional constipation or prepare patients for pregnancy. Common enemas used are phosphate enema, saline enema, lactulose enema, and docusate sodium enema. Uh, on the contrary, a suppository is a small solid or semi-solid plug made from a particular type of medication. The most commonly used type is made from glycerin. Glycerin, although a solid, quickly melts once inside the rectum. Glycerin is an osmotic dehydrating agent that works by stimulating the lining of the intestine as well as increasing fecal water content, making it easier for stools to pass. So, in nutshell, we'll just know that first we have to advise the patient to go for non-pharmacological treatment, that is increasing fiber intake, adequate water intake, and moderate exercise. If that fails, we should add bulk forming agents. If they are also not fully satisfactory, we can add the osmotic laxatives like PEZ or this lactulose. And there are other medicines also for acute relief of constipation. We can use enemas and or suppositories also for that purpose. Thank you.